I'm going to turn it over to John because we always like to start with a few minutes of physical activity. We want to get your hearts pumping. I know the weather here, it starts off like 30 degrees, and by the middle of the day, it's 65 degrees. So I hope you had your sunshine walk today. You got out, you got some fresh air. If you didn't, John's going to get us moving for about 7 to 8 minutes. And then the next voice you'll hear will be from Dr. Monica Parker. She's our associate professor here at the Emory Alzheimer's Disease Research Center. So grab your sturdy chair, go at your own pace, and get moving because movement is life. Thank you all for being here and take it away, John.
Hey, hey, hey! Welcome, welcome, welcome to the Emory Alzheimer's Disease Research Center. Today, it is ab season. We got to get ready for the spring. We got to get ready for those trips. So, y'all get a sturdy chair and y'all get y'all mind right for these abs today and core. But y'all know we're going to get that cardio. In 5 seconds, let's go. 5, 4, Y'all working today. Y'all working today. We're going to keep that tempo up. Let's go. Y'all know. Come on. Watch now. Always do something special for your temple every day. I'm John Lewis, and see you later. Bye.
Thank you, John Lewis. We're always happy to have John start off our weekly webinars to help remind us all that we need to get at least 150 minutes of physical exercise in a week, because that improves blood flow to the brain, and what's good for the heart is good for the brain. Exercise reduces blood pressure. Blood pressure is a major risk factor for developing Alzheimer's or related dementia, and we need to work on that. So today, our presenter, our featured speaker is Dr. Whitney Wharton, who's been with us on several occasions from the School of Nursing. She's a cognitive neuroscientist. Her research focuses on reducing or examining those risk factors that put us at risk for developing Alzheimer's and related dementia. She's been studying vascular risk factors. Vascular risk factors include hypertension, diabetes, also gender and estrogen. Today, she's going to talk to us about sleep, if I understand correctly, sleep and estrogen. Did I get that right, Whitney?
I think I'm just going to talk about women's health in general, but sleep is a huge component of that. So it's something I'm definitely going to be talking about. And if anyone has any specific sleep questions, I'm all about it.
Okay, all right, I'm gonna turn it over to Dr. Whitney Wharton. Again, she's a cognitive neuroscientist from our School of Nursing, and she's examining the risk factors that are making it more likely for us to develop Alzheimer's. And women are at greater risk for developing Alzheimer's, and she's gonna tell us why. Go ahead, Whitney.
Thank you so much, Dr. Parker. Okie dokie. Well, thank you all so much. I see some really familiar names in the attendee list, so it's really wonderful to see so many people that I already know that's engaged in our research thus far, and hopefully make some new friends today and be able to answer some new questions. My name is Dr. Whitney Wharton, and I'm an associate professor in the Emory School of Nursing. I'm actually not a nurse. I wish I was a nurse. I have the utmost respect for nurses. I happen to be a cognitive neuroscientist, and that's how I, when I first came to Emory, was affiliated with the Alzheimer's Disease Research Center. My overall line of research is looking at Alzheimer's disease prevention. So I typically look at modifiable risk factors, things that Dr. Parker was talking about, like sleep, diet, nutrition, sex hormone levels, and then I implement lifestyle and pharmaceutical interventions in people who are most at risk, so that we are able to prevent the plaques and tangles from accumulating in a person's brain, so that once someone, is aging, we don't have to worry about getting the plaques and tangles out. I don't want them to manifest in the first place. So that's what my line of research is about. We have 6 different studies, most of which are funded by the National Institutes of Health. And I'm going to focus on a specific area of research today, which is women's health and Alzheimer's disease prevention. But in all of the studies that I'm going to mention today, specifically these 2 studies, we also were enrolling men. So it's, when I'm talking about sex hormones, especially estrogen and testosterone, both men and women have levels of, or have endogenous levels of estrogen and testosterone present in our bodies. And so we enroll everybody into these studies. So throughout all of this, if you, let's see, in all of these slides, we have our contact info. So we have a QR code. Like now, post-COVID, if you go to a restaurant, you can kind of just use your phone, use the camera on your phone and click on this QR code if that's best for you. We also have a phone number, and then also this is my lab email address. If you want to contact us, someone will contact you this week if you're interested in one or a number of these studies. But all of the studies that I'm going to be talking about today are for individuals who are cognitively normal, who have not yet progressed to mild cognitive impairment or Alzheimer's disease, or you're starting to have some subtle memory complaints, maybe just got a diagnosis of MCI. That's fine too, but because I'm really interested in prevention, I'm trying to catch this before these plaques and tangles begin to manifest. So to start with some Alzheimer's disease statistics, Alzheimer's disease is one of the top 9 killers, the top 6 killers that we unfortunately have not found a cure for yet. And not only have we not found a cure, but it's also on the rise, which is different than others that fall into this top reason, this top mortality rate situation, like heart disease, stroke, HIV, and breast cancer. And one of the main focuses of my research, so when I said that I design lifestyle and pharmaceutical interventions in individuals at risk, I didn't really define what that risk, who those people were. So to me, individuals and according to scientific literature, people that are most at risk for Alzheimer's disease are Black Americans, women, members of the LGBTQIA community, and members of the community that have a pre-existing vascular risk factor. So when Dr. Parker was saying, you know, what's good for the heart is good for the brain, that's absolutely true. So a lot of the individuals in our studies, and a lot of our studies specifically focus on these vascular risk factors like hypertension, diabetes, heart failure. But across a number of different studies, we're really trying to enroll women, because women are more at risk for Alzheimer's disease than men. The two biggest risk factors for Alzheimer's disease are age. So of course, you know, the older one is, the higher risk for Alzheimer's disease that they have. And we know that women are disproportionately impacted by Alzheimer's disease. One statistic that I like to mention, which I think is kind of a startling statistic, is that women in their 60s are twice as likely to develop Alzheimer's disease than to develop breast cancer. And I think when we think about women, we think about any type of disease. If we think about mortality, it automatically goes to breast cancer. And one reason for that is because the Susan Komen Foundation did such a wonderful job in marketing, raising money for research, that you know, we're lagging behind a little bit in Alzheimer's disease. So I want to be sure that you know, we're enrolling both men and women, but it's understood that women are at higher risk than men. And the reason that we think women are at higher risk than men is twofold. So one is the contribution of physiology, genetics, and things like vascular risk factors that are more prominent in women and more prominent in certain times of their life, which I'll go through in a second. But when I talk about sex and gender, I'm talking about sex hormone levels, vascular risk factors like blood pressure, cardiovascular disease, heart disease. But then second, you know, there's also the lived experience of being a woman. And I think that the lived experience of being a woman and everything that goes along with it, you know, I think it's wonderful that, you know, so many women now are in the paid workforce. But just because a woman is in the paid workforce doesn't mean that she is no longer responsible for the home, or for what used to be considered solely, you know, women's work, like raising children, caring for our parents with Alzheimer's disease, caring for our community. Oftentimes that still falls on the shoulders of women. So I think women have just learned to do what we've always done well, but now we do it quadruply well, which is multitask. And so you know, we're working full time, but then we're also going home and still working, but working in a different role. And I do think that it is that concomitant sort of tax on the woman's time, which also then falls into different types of behaviors that I go through, that I do think contributes to a woman's overall risk for Alzheimer's disease. So first, we're going to talk about the biology, right? The easy stuff, the physiology that a lot of us know all too well. So a woman's body is a very interesting and finely tuned machine. It is excessively impressive. The things in our brains and our bodies are largely driven and receptive to changes in sex hormones over the lifespan. And there's a couple of times in a woman's life when there are significant changes in the in sex hormone levels, and these become very evident once we go through these stages of life. So in puberty, for instance, we have these spikes in estradiol levels. So those of you, you know, we might not necessarily remember this about ourselves, but if we have children, we definitely recognize this in our children. So, you know, our 12 to 15-year-old daughters all of a sudden are, you know, a little bit defiant. They know everything. There's these sort, and not to say that the boys don't, but there's, these hormonal fluctuations that aren't necessarily bad, but it's a little bit different than when our daughters were younger. And this is around the time when they start to develop, breasts and things like that. So it's directly related to hormones, but that happens during puberty. Also during a woman's menstrual cycle. There are natural fluctuations in progesterone, testosterone, aldosterone, estradiol that cause changes. So we are, maybe sometimes when we go through the natural menstrual cycle, we might be a little bit more, have a little bit more brain fog. We might be really tired. We might have some mood fluctuations that, again, aren't necessarily negative, but that are different than, the other 24 days out of the month. I think it's also important for me to mention that when I'm talking about changes, I'm not necessarily talking about bad changes. I think that, when we're talking about women's health and we're talking about estrogen fluctuations and things like pregnancy and puberty, oftentimes these are associated with something negative. It's not negative at all. It's completely natural. But sometimes we don't have a word to describe it. So take that for what you will. There's also significant variations in sex hormones during pregnancy. And this is for every pregnancy we have, whether we carry the pregnancy to term or not. And this lasts for a little bit after we are not pregnant anymore. And for the purposes of this talk, what I'm going to be focusing on is menopause and the menopausal transition, which is the time of life when we have significant decreases in types of estrogen. So when a woman goes through menopause, her levels of a certain type of estrogen significantly decrease. So the type of estrogen that is produced in a woman's body before menopause is called estradiol. And you've probably heard that in conjunction with hormone therapy, like an estradiol patch or something like that. So that is the type of estrogen produced before menopause. That type of estrogen, the estradiol, is produced from our sex hormones, from our ovaries and from our uterus. But when we go through menopause, we stop ovulating, so we don't have periods any longer. And there's eventually we are not able to use our ovaries in our uterus anymore. And we stop producing estradiol because that's where it comes from. However, the body is not done with us. What happens after menopause is that our bodies start to produce a different type of estrogen. And that type of estrogen is called estrone. And that estrogen is not produced from our sex organs. That estrogen actually comes from fat tissue, from adipose tissue. And the reason that women begin to accumulate a little bit of extra cushion, a little bit of extra fat tissue around our hips, our thighs, our rear ends during and after menopause is because that is now where our estrogen is coming from. And that is protecting your sex organs. So I've said this once, and I will say this a million times in these BrainTalk lives. The worst thing you can do when you are going through menopause, or if you are postmenopausal, is get rid of that fat tissue. So you don't want to go and get liposuction and suck out all of that great protective tissue that is producing this estrogen that's now feeding your brain receptors. Don't do that. As long as you are healthy, you are happy. It's okay to have an extra, 10 to 20-ish pounds as long as you're okay. Our bodies just change in exactly the same way that our bodies change, or not exactly, but similarly to the way our bodies change when we first had these different fluctuations in sex hormones and we went through puberty in the first place. So it's the, different end of the spectrum, but there's just different things happening to our body. The only reason it's more problematic than going through puberty is because society has told us that it's more problematic, but it's not. It's really not. It's there to protect you. Every single woman, if we are or lucky enough to live to the age to go through menopause, will experience this. So, is like I said, as long as you are happy and healthy and, eating right and exercising, that's there for a reason. So what happens during menopause? Not only are we losing these our markers, our biomarkers of estrogen are changing, but there also are physiological consequences of this estrogen depletion. So when your estrogen levels drop, our heart and our blood vessels become much less flaccid, much less elastic. So if you think about, all of us are, kind of getting ready to plant our gardens and going outside, and you'll oftentimes like pull your hose out that you haven't used all winter out from under, in your behind your house or in your shed or something, and the hose is kind of stiff and hasn't been used in a year, and you have to kind of shake the dirt off of it. It's a little bit, you need to turn it on, and there'll be some, it takes a little bit of time for the water to actually get through it. Well, actually, the exact same thing happens in our blood vessels. So, because the estrogen levels have dropped a little bit, the stiffening of our blood vessels is a lot like a hose. And what we don't want to happen is for continued stiffness of our blood vessels. So we have to work much harder than when we were younger to keep those blood vessels elastic, to keep them mobile. Because what you don't want to happen is like a square, like a kink in the like an L-shaped kink in your blood vessel, because what happens is the blood will want to come one way, and then we'll need to go down to a different part of your body, let's say going from your heart to your arm. And what happens is the blood comes and slams into the side of this blood vessel, and it causes this sort of vortex of blood. And that's if the blood vessel isn't flaccid, where if the blood was able to come through and kind of go, naturally around like a slide, it would be much easier. But if it's this very static L-shaped blood vessel, the blood is going to come slam into this, cause this vortex of blood, and then eventually go down. But the vortex causes the lining of your blood vessels to become more worn out, because it's just a bunch of blood circulating in that one area. And so that's what we don't want. So the more that you can do to keep your blood vessels moving and flaccid, and the way that you do that is by increasing your heart rate and exercise. I don't care what you do, it doesn't matter. You can go outside and garden. You can go bowling, you can do yoga, you can, on your lunch break, walk around the parking lot 3 or 4 times. It is a beautiful day outside today. If you can safely walk around the block, if you can walk around your house, when you go to the grocery store, if you can park, again, safely at the end of the parking lot instead of parking right by the door. Taking the stairs versus taking the elevator. This seems like a small thing, but all of these are very additive. So if you think that, for instance, if you live in an apartment complex and you live on the second floor, well, if you take 2 flights of steps up, and when you leave 2 flights of steps down, and you do that 3 times a day, that's 6 flights of steps. That's not inconsequential. So anything that you can do like that is really, really helpful. And the reason that we do that is because it will decrease the incidence of these vascular risk factors, which include hypertension, hypercholesterolemia, heart disease, diabetes, and it will keep your weight in check. So in addition to the blood vessels, there are also ramifications of estrogen changes in the brain. So when I was talking about estradiol, which again is the primary circulating hormone in a woman's brain before menopause, this area of the brain in the very center called the hippocampus is just chock full of these estradiol receptors. And the hippocampus is the memory and thinking center of the brain. And that is an area of the brain that is primarily impacted by Alzheimer's disease. And so this is one reason that we think there is that direct contribution of sex hormones to Alzheimer's disease. Coincidentally, the area of the brain, the memory center of the brain, this hippocampus, is smack up next to the emotion center of the brain, which is called the amygdala. The amygdala not only is directly next to the hippocampus, it is also just chock full of these estradiol receptors. So whenever we have fluctuations in estrogen, whether that be from puberty, from the menstrual cycle, from pregnancy, from menopause, these two areas of the brain are just lighting up, they're firing, lots of things are happening, and they're talking to each other. And so it makes sense, right, that when we're going through menopause, we'll have some mood related changes that again aren't necessarily bad, but they're not what we had before menopause sometimes. They also, that's also the reason that we might have some brain fog, some menopause brain. And that's just because this is the memory and thinking center of the brain. So this is also related to the prefrontal cortex, which is also just chock full of estrogen receptors. So, the reason that all of these symptoms are happening when we have these sex hormone fluctuations is because that's just where our estrogen receptors are. It is nowhere our fault that we are, having these sort of these behavioral these symptoms of these hormone fluctuations. Then if you were to smack your arm on the table and get a little bruise, same thing. It just is happening in your brain. The good thing about menopause is that whether it's surgical or natural menopause, the symptoms almost always, sometimes with the help with hormone therapy, but they almost always dissipate after a while. It can seem like a really long time. And so for some women, it is a really long time, but they almost always normalize. But your body has to become accustomed to a new hormonal makeup, a new hormonal milieu, if you will, of what our new levels of hormones are going to be. So that is the physiology. I also said that I think women are more at risk for Alzheimer's disease, not just because of the physiology, the biology, the genetics, but because of the lived experience of being a woman. So as I mentioned, we're more likely to be paid in the paid workforce. We still, don't make as much money as our male counterparts, but we are very much more likely than we used to be in the paid workforce. But this does not necessarily mean that our responsibilities at home go away. Oftentimes women, especially, women who opt to take part in my research studies, a lot of them have full-time jobs. A lot of them have children in the home that they're still caring for. Or if they have children, they might not be in the home, but they're still supporting them at least partly financially, for sure. And then most of the individuals in my study are caring or have cared for their parent with Alzheimer's disease or related dementia. So all of these different, these are three different facets of life, any one of which is a full-time job. And raising a child is a full-time job. Taking care of a parent with Alzheimer's disease or related dementia is a full-time job. Having a full-time job is just what it sounds like, having a full-time job. So all of a sudden women are doing all three of these, and we're doing it oftentimes at the time of life when we are having these natural physiological changes associated with hormone fluctuations. So women during middle age are going through a very unique change, not only physiologically, but in our own lives. And not everyone does these, and some, not everyone has these three buckets, but a lot of women have additional buckets, or you might be caring for, multiple parents. You might be caring for your parents and your partner's parents. Maybe you don't work full time, but maybe you volunteer. But I haven't had someone doing, one or a few of these buckets that still doesn't feel pretty overwhelmed, especially because it is compounded by these physiological changes. And sometimes we don't talk about those physiological changes enough. So I just wanted to mention a little bit about women and caregiving. And this can be, any caregiving role, but I wanted to mention specifically the caregiving surrounding Alzheimer's disease, because this is the Alzheimer's Disease Research Center. So 1/3 of women who are Alzheimer's disease caregivers are 24/7 caregivers. And 40% of these women say that they did not necessarily feel like they had a choice in becoming a caregiver. And that doesn't mean that they would not have done it. But a lot of women will say, well, of course it's me. I'm the firstborn daughter, or I live in the same city as my parent. There's no one else, and I'm not sure what else to do. So I think that person is just me. 2/3 of all working caregivers report having to go to work late, leave early, or take time off to provide care. And then on top of that, you have the intersectionality of race and gender. So if we're talking, for instance, about a Black woman, a Black American woman versus a white woman, then we also have a wage discrepancy there if we're talking about working full time. And we also have additional social determinants of health that compound how a person is able to navigate through their world and access to resources. And so some of these risk factors can absolutely become compounded. There is a also significant area of research that commonly talks about Alzheimer's disease caregiver stress and depression. So 60% of Alzheimer's caregivers rate the stress of caregiving as high or very high. And about 40% of Alzheimer's caregivers suffer from depression. Both high levels of stress and depression are themselves independent risk factors for Alzheimer's disease. And it's really important because women experience depression at twice the rate of men, and fewer than half of women will ever seek care. And we just think it's normal. So we already know we're feeling different because we're having these physiological changes that are associated with the menopausal transition. And again, those last a while. But then, it's compounded by so many things that are going on in our life. And we're like, this is kind of how the world works now. And this is something that I'll get used to, and eventually I'll catch up. And especially if we're caregivers, so much of our time is devoted to caregiving that we don't have a second to step back and say, how do I feel? What do I need? Because so many women just put themselves second or third or fourth. And it's not because we're actively, trying to practice self-neglect. We just are more concerned with others than ourselves. Which is exactly what a caregiver is, right? So, but it's important for you to care for yourself, not only because it's important for you to care for yourself, but also it will make you a better caregiver if that gives you an excuse to do it. And the person that you're caring for would ultimately want you to care for yourself. And sometimes we just have to step away and take our own time away. I mentioned a lot of these earlier, but I just wanted to touch on, sleep disturbances and trouble concentrating. So there's a few things that go along with the menopausal transition and stress in general, that sometimes are common among middle-aged women. So trouble sleeping. There are appetite changes, lack of exercise, or just not being able to move like we used to. So that makes us less likely to want to exercise. But the sleep disturbances, kind of like the menopausal transition, I'll touch on that for a second, is it's interesting because it's kind of like menopause. You know, you don't one day sleep perfectly, and then the next day you need a CPAP machine or you have restless leg syndrome. So a lot of women who are in our research studies don't actually even know that they're having sleep disturbances until they come in and we send them home with this device that they wear overnight. And it turns out that they were up and down all night, they were moving around, and it's not necessarily because we hook them into this machine. They just didn't even know, because we also have them fill out a sleep diary. So they didn't even know this was happening. And then if we were to interview their partner, if they were to share the same bed with someone else, and we were to ask them, they would say, oh yes, you know, that, you know, she snores and she moves around and she gets up and goes to the restroom more than she used to. And you know, she wakes up earlier and it's just kind of more choppy. That happens a lot. And again, it's not one of those things that is fine one day and not fine the next day. It's just one of those things that, you know, unless it's super, super problematic, we tend to kind of sweep under the rug. But there's things that we can do. And the good thing about all of these risk factors that are listed right here on this page is that all of them are modifiable. We can change all of them. But step one is realizing and identifying that a potential problem exists and that there is something for which we can seek help from a number of different doctors. You can do it through research participation. And I'm about to tell you about a research project that looks at all of these different factors, so that at least that will give you an idea of whether or not you think that, you know, that you're having an issue with this. So one of the studies we're doing right now is called the E2 study. It's called E2 because that is the formulation for estradiol. This study is being conducted on the Emory campus in person. You do not need a study partner for this study, and it is not a clinical trial. This is a 2-year observational study, and this is for both men and women. And what I'm really looking at is the influence of sex hormones on outcomes related to Alzheimer's disease and these vascular and behavioral issues that we know are related to Alzheimer's disease. So there are 3 to 5 study visits over a 2-year period. And I just say 3 to 5 because the baseline visit and the year 2 visit are kind of long. But if you're taking off work to do a study visit, you might want to do everything in one day. It's about a 5-hour long study visit. But if you want to do it in 2 days, we can do it in 2 days. We are looking for men and women 40 years that actually changed from 45 to 40 years and older. We have about 150 people in thus far, and we're looking for about 50 more. We are trying to recruit individuals who have normal cognition or mild cognitive impairment. And if you're interested, again, this is the phone number, the QR code, and the email address where you can contact my team directly, and we will call you back sometime this week and get you scheduled. There's compensation for $300 participating for the study. And some of the research results we give back to you, like the results of the sleep profiler, which is photoed right here. Not sure why that keeps happening. So these are the outcomes we're looking at in the E2 study. So again, what's good for your heart is good for your brain. And I want to see exactly what your blood vessels are doing. So we have you lay down on a bed, and we do a non-invasive ultrasound, kind of like if you think, if you've ever seen, you had yourself or seen on a movie when, you know, there's some jelly involved and we're, you know, putting a wand over your blood vessels. We just do that on your arm and on your neck to see how thick your blood vessels are and to see if there's any plaque accumulated. We also have about an hour-long MRI, which takes place right across the street from the Emory School of Nursing building. We also provide free parking. Of course, we give you all of the directions that when you're here, and you'll be working with the same clinical team our entire time. We also do blood draw, so I can look at markers of inflammation and Alzheimer's disease in your blood. We have about an hour and 15-minute long cognitive assessment battery, including this test right here, which is a number of you are probably familiar with, called the MOCA. These cognitive tests are designed for individuals who are, cognitively normal, who are above average intelligence, which that is exactly who's on this call today. Because if you are enrolled in or considering enrollment in a research study, those individuals are normally just more intelligent for some reason than the average person. So these tests are very challenging. But if there's a problem or something that I would not expect, given your age, your gender, and your education, then I call you and we have a conversation and we handle it however you want to. We also have a lumbar puncture involved in this study. We do this we do this twice over a 2-year period. And I understand that lumbar punctures are a big ask. I absolutely understand it. The only reason I ask is that this is the very best way for me to be able to know what's going on in your brain. It's not as clear with the MRI, and so I really need to know what plaques and tangles are doing over time and how many of them might not be in your spinal fluid, which is an indicator of what is in a person's brain. And then one of the bonuses of being involved in research, particularly those projects that do have invasive procedures like a lumbar puncture, is that we do track you over time. So we are able to see if these plaque and tangle markers change over time. And then the last component is this very cool sleep profiler. So we are one of the first studies to ever use this. And this is simply a headband with what can best be described probably as a battery pack that goes on the front. And this is the equivalent of an in-person sleep study. Like if you were to, come to Emory, spend the night here, and we hook you up with all of these electrodes and a cannula and a belt around your leg. But who wants to do that? Not me. It's really hard to get an accurate reading. It's really hard to sleep. And I've just heard some participants say that was their least favorite study that they have done because it was just such a long night. So this is not at all to say that this is replacing a sleep study, but this is the equivalent of a number of components of a sleep study, but you get to do it in your own home. You bring the sleep profiler back to us, or we can meet you halfway and come get it. But it's one night in your own home, in your own bed, on the night that you choose. So we just wanted to make it as comfortable as we can for you. So I am about at time. So I will stop here and just say thank you so much. If there's anything that any questions that we can answer for you, again, this is the phone number. This is the website, and thank you so much for your time today. I really appreciate it.
Thank you, Dr. Wharton. Dr. Parker, do you want to moderate questions? We have about 5 minutes.
Sure. Okay, so one of the things that they have here, I'm increasing my risk factors for Alzheimer's if I'm using estradiol cream. I'm postmenopausal, sexually active with one partner. So can you talk a little bit about the use of either topical or oral estrogen and risk for Alzheimer's in women?
Sure. So this is something that, a decision that every woman needs to make based on your own physiology, your own risk factors, and your own symptoms that you're experiencing. If, a lot of the symptoms that go along with menopause are related to sex and sexual activity and things like pain during sex. So when women go through menopause, we have increased incidence of vaginal dryness and decreased just interest in sex in general. And it can just become, physically uncomfortable for us, but then also it impacts our relationships, right? And nobody wants that, especially when we're, going through all of these other life changes. So if the symptoms are oftentimes associated with, vaginal dryness or something, the physician will most often recommend a cream. And it's really important also to consider the route of administration for how long you want to take the hormone therapy. So there was if any of you want to do any type of research, the follow-up study to the Women's Health Initiative, the Women's Health Initiative was the first clinical trial that came out that kind of scared everybody, saying that hormone therapy was going to cause cancer and everyone was going to get dementia. Well, that actually doesn't happen, but they did the clinical trial in the wrong people. And so we did a follow-up clinical trial to the Women's Health Initiative. And what we found, number one, is that for at least 4 years, it was safe for a woman to undergo hormone therapy, whether it was a patch or a pill or whatever kind of medication she would take, again, depending on the symptoms that she was having. But this, again, is really important to talk with your OB-GYN or your family physician. It's also really important to take into account what if you have a personal or a family history risk factor for breast cancer or ovarian cancer. That's something that you also want to weigh.
So just to tag on to what Dr. Wharton has explained, the idea of taking an estrogen supplemental treatment beyond 5 years of menopause, 5 years of menopause is not helpful. It is more likely counteractive with respect to brain dysfunction. Topicals can be used, as Dr. Wharton has explained, but the oral medication is not effective. I saw a question in here about 20 years of estrogen therapy, and that generally flies in the face of good medical management and puts you at greater risk for developing Alzheimer's. So the oral estrogens were designed not to be taken for forever, but for the 5-year perimenopausal period. But after that, when menopause sets in, the value of oral estrogen is not really good for you. So there is a question in the chat also about, are you supplementing estradiol in the study, Whitney?
No, we are not. However, I do have a clinical trial for older individuals called ACE, and you can use the same number, the same contact number. It's my same team that runs that study. And I don't do pharmaceutical studies, but I look at off-label use medications that we know are either FDA approved or they do not need FDA approval. So I have a soy clinical trial going on right now, and we're using a metabolite of soy because it is so chemically related to estrogen. So if you're interested in something like that, please also contact us.
Okay, can somebody out of state participate in any of your studies?
You can, if you will be here at least once a year for 2 years. So we have a number of individuals that come in either for fun, because it's Atlanta and it's fun, or because they have family or friends or business might bring them here every once in a while. But it does unfortunately have to be an in-person visit because our MRI machine is here, I'm here, our physicians are here that do our lumbar punctures for us. So it is an in-person visit. But I have someone that flies in every year from Texas. There's people that drive in from Tennessee, like last week. We have a number of people that have been in our studies, and people actually who I followed for almost a decade now, who are still in our research studies that just, I guess, had a good experience and come back year after year after year. I know it's like 2 of them at least are on this call right now. So.
Okay, I know that you probably answered this in the course of your talk, But the question from Miss McKenzie is, can you talk about how sleep deprivation and menopause kind of figure into the development of Alzheimer's and dementia? And before you answer that, I think that this individual probably needs to also check in with his or her doctor just to make sure that all metabolic things are okay. So I guess the question is menopause and sleep deprivation, are they contributing to her fatigue?
Almost certainly, I would imagine. But I would do just what Dr. Parker said and suggest that you speak to a clinician about this. But there's a lot of different factors in play, and then some simple blood tests would be able to give you a number of answers. So, for instance, if you were to come to the sleep clinic here at Emory, and one thing that I look at in my research studies and the E2 study I just mentioned is I look at levels of what's called orexin, and that is a marker of sleep that we get through. That's also something I'm going to be looking at in blood and in spinal fluid, not just Alzheimer's disease biomarkers. But the thought is that your orexin levels become really wonky, both through the menopausal transition and just naturally with age. And that is the compound that is directly related and regulates sleep. And there have been links in the literature between orexin and Alzheimer's disease. So you kind of get this perfect trifecta storm of increased risk of Alzheimer's disease. So it's not necessarily the sleep, right? Like the sleep, the physical act of sleeping that's related to Alzheimer's disease, but it's what causes it and what goes along with it. So the sleep is the symptom, but something is causing that. And we think that it's probably the orexin, the increased stress, which does things like increase our markers of inflammation, increases our blood pressure, and then also these altered hormone levels. So all three of those things are also cause increased risk for Alzheimer's disease. So if it's one or all of those, that's why sleep is implicated.
So on that note, and I think from a primary care perspective, if you're experiencing greater fatigue, sleep disruption is certainly a reason to have daytime fatigue, as is an underactive thyroid, as is anemia. So those are things that you need to check out with your primary care doctor to make sure that those things are in line or in where they're supposed to be. In addition to that, sleep disruption studies, sleep apnea is something that can be diagnosed and needs to be managed. And those are medical things that need to be addressed before you jump through all kinds of conclusions. So anytime you're having any kind of physical symptom that is not consistent with an enjoyable quality of life, please address those sorts of things with your primary care doctor, because there may be some underlying disorder that is treatable that can manage that. And let's not overlook the fact that some people who are undergoing a lot of pressures and stressors, caregiving for more than one person, the life, trying to balance work life, there are affective disorders, both anxiety and depression, that can contribute to some of those symptoms. But again, that's something best discussed with your doctor. And one last question, Dr. Wharton, there is somebody who talked about testosterone and what's its effect in comparison to estrogen on the brain. Do you?
Yeah, for sure. So that is something, again, both men and women have testosterone endogenously, both in our plasma, in our blood, and also in our brain. And that's why I'm measuring it in women and men who are in this study. So men go through also a different but a similar type of depletion as we age. So we just happen to know a lot more about male physiology than we do about women's physiology. But we do measure males and females testosterone levels in this study. But we have a number of men on testosterone replacement therapy, on hormone replacement therapy. Men with low T, men that take all different types of supplements. There also is there's also a seasonal variation in men that we account for as well. But men also go through a type of menopause, but it's called andropause for men. So that is something that's very real, also impacts these same kind of symptoms that are influenced in women.
Okay, so we're 5 minutes over. Thank you, Dr. Wharton. That was the last question. Thank you so much again for presenting to our audience today.